My name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Farrow, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello, my name is Albert Farrow, and I'm the chairman of the editorial board of the journal Medicine. And I'm delighted to have with me Dr Alexandra Bonsall. So welcome, Alex.
Thank you very much for inviting me.
Delighted. And the reason that Alex is here is because she is one of the board members. She's the board member who supervises dermatology. And we're recording this in July 2025, and the July and August issues of Medicine are all about dermatology. So it'd be nice to talk a bit about dermatology with you, Alex, and perhaps just start off just saying who you are and a bit about yourself.
Thanks very much. So my name's Alex. I'm a dermatology consultant in Aberdeen. I did my training up here. I started as a registrar in 2012 and then became a consultant in 2017. And I specialise, I suppose, in everything because we all do a bit of everything up here. But I do a severe psoriasis clinic, which involves the use of some interesting medications. I do skin cancer and also enjoy other inflammatory skin problems and rare, weird things as well. And then on the side, I'm involved in university as a careers lead, and I've become involved as chapter editor for the dermatology edition of Medicine, which has been fantastic. And thank you for having me along. So yes, I think in terms of dermatology, really, I've been very lucky in my time in terms of when I started. In my first week as a registrar, we still had a ward in Aberdeen. And so we were still doing an awful lot of TAR treatments for psoriasis in particular. And that continued for another year or so, but that's been completely changed. Since 2012, we've had a kind of complete revolution, really, in terms of management of skin disease. Psoriasis in particular, it was a bit of the pioneer when it came to use of biologic medications, and all the progress that's been made since in that area. So I think the first thing we were going to speak about was a bit about that.
Yeah, no, absolutely. I think it'll be good to talk about how the face of dermatology treatments has changed over the years. And just to say to the viewers and listeners that we can't obviously cover everything in dermatology in the space of 15, 20 minutes or whatever it is that we're going to talk for. We're going to talk about things that we think are interesting and topical, but actually there's lots to read in the July and August issues. So if viewers and listeners would like to learn more about any topic, whether we talk about it today or not, please do go to those issues and read more. Well, let's talk about treatments in dermatology. As you say, things have changed a lot in the last decade or even more. So tell us, I mean, I remember, when I was a medical student and a junior or resident doctor, as they're called now, we were quite limited. There were sort of topical treatments. We had steroids, methotrexate perhaps, and one or two other systemic treatments, but not much else. But things have changed a lot, haven't they?
Absolutely. And that's really been fantastic for patients and for doctors. Certainly, as I say, when I started, my bosses, the senior consultants at the time, had spent their careers using topical treatments, then methotrexate and cyclosporin. And it was only really since the early 2000s that we started having trial patients that were taking the first biologic medications. And they just completely revolutionized treatment of psoriasis to begin with. You go from treating somebody with really severe disease. We're talking kind of head to foot psoriasis, awful stuff that used to get them hospitalized and things. They would have intermittent courses of methotrexate until they had issues with side effects, and they might get a bit clear, but expectations are very much limited. And then we used the biologics, and people were suddenly getting 75 to 90% clearance across their body. And it changes people's ability to form relationships, ability to go to work. And it means they don't need to come into hospital. So it was a terrible thing. Losing the dermatology wards was something that happened across the UK. I think there's still a few in selected sites across the country, but really not very many. And most of the patients on those wards were psoriatic patients who would spend 2 to 3 weeks getting tar every day and then might go away home after that. And now these people aren't doing that. They're out walking around, holding down a job, having families, and we see them maybe once every 6 months or so. None of the treatments we have are a cure for the condition. So these are all things that, if we take the biologics, for example, they're mainly monoclonal antibodies, they're given by injection, and they go and they block a specific interleukin or cytokine in the body that's been identified as one of the drivers of the inflammatory cascade that leads to psoriasis. They block it and stop it from causing its fuss that it wants to make. And that prevents people from having the degree of psoriasis that they once had. Everybody's different. We have people who might start a biologic and stay on the same one for 10, 15 years and they're still going strong. We have other people who might take it for 5 years and then it gradually seems to wear off. And we still do have some who might try one and it doesn't work for them. But on the whole, the landscape when it comes to psoriasis has completely changed. The biologics are well tolerated and people get minimal side effects with them. And there's very few contraindications as well. I mean, you can't use them with active infection. With the anti-TNFs, you don't use them alongside demyelination, so multiple sclerosis or any symptoms that could potentially lead to that. But otherwise they can be used in the vast majority of people. So they're a wonderful class of drugs. And from their use in psoriasis, they've then spread out to use in other conditions such as hidradenitis, a whole variety of different things. And then the lesser common things as well, where we use them off license, like PRP and all kinds of things. So it really has been really satisfying to have seen that different that just happens to coincide when I've been working and training. That's the biologics. We've also then got other treatments as well that have occurred in the last 5 to 10 years. So that includes the small molecules. So I suppose our first small molecule was a Premolast, which blocks PDE4 and again is a psoriasis treatment that's being used for other conditions too. And then latterly the JAK inhibitors, which we now have several of, and they're used in other specialties as well and for a variety of different conditions. The main thing, I suppose, the biologics are given by injection because they're big proteins. And if you ate them, you would digest them. Whereas the JAK inhibitors and the small molecules are little, so they can be taken orally. Which helps with people who are needle phobic, for example. We do have a few people who refuse to have a biologic because they're so needle phobic. The JAKs, so they block these enzymes called JAK1, 2, and 3. There's JAK1, 2, and 3, and then there's a thing called TYK as well. And these enzymes sit in the cell wall. And normally they attach to something called STAT that's inside the cell, and then that goes off and it again starts this inflammatory cascade, excites a whole bunch of cytokines and causes a variety of diseases. And so in dermatology, we use JAK inhibitors that block usually JAK1 or 2. Quite a lot of them block JAK1, and we use those for eczema. We can use them for many other conditions as well, often out with their license. And then in alopecia areata, which has been in the news and on a variety of forums since then. So again, they're a good drug. They're very effective. They work faster than the biologics, which is good news for patients. You probably wait about 4 months to see the proper response to a biologic, whereas within a JAK, you might have significant improvement in your itch within a few weeks, even, which is great. Because the JAK proteins can have an effect on quite a lot of different interleukins and cytokines. So they can have more wide-ranging effects. So they do tend to have a few more side effects than the biologics. They can cause infections, they can cause acne, headaches, GI upset. And then the most significant thing from when they first appeared was the potential higher risk for strokes and blood clots, which obviously is a big discussion we have with patients. And we're still as with all the new drugs, it's only really when you've been using them for a good 5-10 years that you get a full idea of how these things work in the real world with our particular cohort of patients in dermatology. So we're still learning stuff about them. And it's an important discussion to have with patients as well, because a lot of patients will believe that we limit access because of cost. And certainly that is part of the issue. The biologics and the JAKs still are expensive drugs, but it is also safety. Whenever we've got a new drug, probably in any specialty, we want to use it in people who've got severe disease where other things haven't worked. And we want to find out more about it. And it is with that sort of first 5-10 years that we really gather all the safety data, and then we can be a lot more confident in use of it. But they've been again, a fantastic addition and an option when it comes to treating severe disease.
Indeed, game changers, really. It is interesting, isn't it, how biologics have really transformed so many areas of medicine. Dermatology is a clear one, but rheumatology, oncology, they've made such a difference in so many areas. And the JAK inhibitors, as you say, are a very interesting class as well. And you mentioned alopecia areata earlier on, and I think that's a particular area where the JAK inhibitors have made inroads, isn't it?
Absolutely, yeah. So with alopecia areata, obviously people get it to different degrees. So you can just have a very small patch that might come and go over years and just be treated with topical treatment. But for more significant alopecia areata, so in cases where people have lost more than 50% of the hair on their head, ritlecitinib was okayed for use in the UK as of last year. And it's the first real kind of beneficial treatment that we've had for alopecia areata. In the past, we'd have these people come in, and it's a very emotional consultation. It's it has a massive impact on your life. It's such a visual thing. And we didn't really have a treatment for it. People have tried things like prednisolone or immunosuppression, and they didn't really work, and they do have potentially significant side effects. So that was always a tricky risk-benefit discussion, really.
But then I remember a particular treatment that I used as a hypertension doctor, minoxidil, which was often touted in these patients. Is that still used at all?
Yeah, so it's used for a variety of forms of hair loss. Yeah. We often suggest it topically, so minoxidil foam that people can buy, and that might be for female pattern or androgenic alopecia or telogen. It does have a little role in alopecia areata, but probably not so much. And oral minoxidil isn't something that locally we tend to prescribe on the NHS, though I think it is gathering its use. But again, not so much for alopecia areata, more for the androgenic alopecia or telogen. So yeah, with ritlecitinib, again, it's something that we can offer patients. Not everybody responds, so it's got about a 40 to 50% proper response rate. And it's a bit of a slow burner again, so it might be 9 months into treatment before people actually get regrowth. So you've got to continue it in that time, keep with it. And then the thing is as well, that if they do get regrowth, we are looking certainly at the moment at continuing the drug long term, because if you stop it, then there is that chance the hair growth can come out again. So that again is a discussion to preempt, pre-warn your patients about. For one, that if it doesn't work, we're going to stop it. But also if it does work, then it's a case of staying on it, because again, it's a JAK inhibitor, so it does have those risks of infection, potential increased risks of blood clots and stroke. So there are some patients that we avoid these medications in. So if you're above 65, if you already have cardiovascular disease risk factors or other comorbidities that would put you at high risk, then we wouldn't use them. But for appropriate patients, again, it's not an option.
Great, yeah, that's interesting. Maybe move on to another disease area, which is in the July issue. And in fact, there's a few conditions that are in one chapter. So hidradenitis suppurativa is put together with acne and hyperhidrosis. I guess they're all disorders of skin glands overproducing stuff. But hidradenitis suppurativa, I think you mentioned that earlier on. Maybe just sort of say a little bit about what it is, because I think it's not very well recognized, is it, by a lot of doctors?
Yeah, exactly. So it's a condition that really, again, can not exaggerating at all. It can destroy somebody's life. So it tends to affect women rather than men, onset between about the ages of 20 to 40, and then it might get better at the menopause. And it causes nodular, suppurating, scarring, fistulating lesions that tend to affect areas where there's apocrine glands, so armpits and your groin, and it can sometimes be elsewhere in the body too. And yes, I think historically, a lot of people have never sought attention for it because they were embarrassed because doctors didn't know what it was. So they would assume it was related to their weight or their cleanliness or whatnot. So there was this big kind of stigma around about it. And patients were not treated well. I think we recognize that. There's data that suggests that if you have hidradenitis, it would take you 7 to 9 years to get a diagnosis. And if you're onset age 20, I mean, that, you know, it's hopeless really. So what has happened, and I think this has been a really good side of social media actually, is that it's put people more in contact with each other. So there's people that are saying, I've got this too, you know, and then there are forums and things, and there's obviously kind of downsides to it, but there's a lot of positive in that patients actually feel like, look, yeah, I've got a thing, you know, this is what it is, and then they can talk to health professionals about it, and then it raises awareness between health professionals as well. So the other thing that's happened is we've had better treatments for it. So as well as kind of raising awareness that this is a condition that does affect people, it's a medical problem, it's not related to anything else, we have better options for treatment. Nothing is perfect as of yet. There's still a lot of work to do, but we are getting somewhere. So it used to be that people would, well, and they still get long courses of antibiotics. So we use tetracycline antibiotics quite liberally in dermatology. Both for acne and hidradenitis, people would get 4 to 6 month courses of tetracyclines because that particular group has been found to reduce inflammation in these conditions. If people had no response to that, then for HS, they might get a combination of clindamycin and rifampicin and have that for 3 months. And that was a phone call that I once got at 3 o'clock in the morning. There's some people are asking what we do in dermatology on call. So 3 a.m, I'm asleep, and had a phone call from out of hours saying, I've got a lady who's got horrible cellulitis with pus dripping down her arm, and it must be really, really bad. So you've got to come now because she's been on clindamycin and rifampicin for 3 months and she's no better. And I was like, yes, this is hidradenitis. It's a shame. So what we have now
it's good to know that dermatologists even get woken up at 3 a.m. I didn't think that happened.
There you go. But I'm sure you've got many, many more stories than I do about that. Yes, now we have the biologics. So a few years ago, adalimumab was approved for management of HS, and then latterly we've had secukinumab and bimekizumab more recently as well. So adalimumab's targeting anti-TNF, and then secukinumab, bimekizumab are IL-17, and then the JAK inhibitors, I believe at the moment are still off license, but there is evidence of benefit there too. But there's not been quite the same massive improvement as we saw in psoriasis. So we're still looking to find what is the right thing to do in HS. It's a multifactorial condition. So patients that suffer from it do tend to have a higher BMI, although that's not always the case. We do see it in people who have a normal BMI as well. They can tend to be smokers. How much of that is confounding and how much is caused, you know, I'm sure. And there can be a genetic link, so it can sort of run in families. It can be linked to other conditions as well. So it can be linked to other sort of follicular occlusion problems like pilonidal sinus or acne, and also other inflammatory diseases, so ulcerative colitis and forms of inflammatory arthritis as well. So yeah, we're working on making those patients' lives better too.
So good advances in its treatment, but the important thing is to recognize it in the first place.
Absolutely, yeah.
And you mentioned acne as well, which, and that's also in the same chapter. Obviously very common, especially in teenagers. I have teenage sons myself, and I know that this is a big worry amongst their friends, how to treat their acne. And many of them, as you said, are on tetracyclines for long periods of time and topical treatments. And the thing I thought we might sort of just focus on is the use of isotretinoin, because of course that's an effective drug, isn't it? But there's been worries around it, and maybe you could just sort of tell us a bit of background on this.
Yeah, sure. So isotretinoin is an oral retinoid. So the retinoids are a family of drugs derived from vitamin A. We have topical ones and we've got a few oral ones as well. And we use them for a variety, again, of skin conditions, but acne is the main one probably. Now, if you have acne, the first thing people will tend to try through their GP is a combination of a topical retinoid, so a retinoid cream, and an oral antibiotic, usually a tetracycline. If that fails and the acne is severe and it's scarring, then the next best option is a course of isotretinoin, which is the oral retinoid that we tend to use in acne. And it works by a number of different ways, kind of skimming very quickly over the pathogenesis of acne. But you've got a number of things that happen. There's increased sebum production from the skin. You've got overgrowth of the pores by the keratinocytes, and you've got an overreaction of the immune system to particular bacteria that live on the skin surface. And isotretinoin tries to correct as many of those things as it possibly can. And what we find is that if people complete a full course of treatment, so if they, over the course of 6 to 12 months, receive 120 milligrams per kilogram of their body weight or 150 milligrams per kilogram, that will switch off the process of acne. And about 80% of people will have a really, really good response to it. There are some people who might have a course of isotretinoin and then a few years later have acne again, and some people need a second course. There's a real minority who stop isotretinoin and find the acne comes back straight away. And usually that's because they've stopped it too early and not reached that cumulative dose that's been found in the evidence base to give you the best chance of switching off the acne. So it is our most effective drug for acne, but like all medications, it can cause side effects. The really common ones are skin dryness. So everybody gets dry lips, dry nose, sometimes dry skin elsewhere, and they use lip balm and moisturizers for the course. Your body gets used to retinoids as well. So we tend to ease it in. So start at a relatively low dose for that patient and then gradually increase it. And that can help the body adjust over time and reduce the chance of side effects. It can cause things like muscle aches in people. And again, that can be a dose dependent thing. In people of childbearing potential, it is a teratogenic drug. So there's always been this thing called the pregnancy prevention plan that runs alongside it. So anybody who could become pregnant, we advise them to use contraception, at least 2 forms. They often need to have monthly pregnancy tests when they're on the course, unless they fit in with certain criteria. So it is heavily monitored that way. And it is already a specialist only drug. So it's only dermatologists or dermatology healthcare professionals that can prescribe it and use it in the UK. So it's always been quite heavily looked at. But one of its other side effects is mood. So in a minority of patients, because the majority don't have an issue, in a minority, there can be changes in mood when they're on a course of isotretinoin. And that can be things like not feeling as happy as you usually would, or being less able to concentrate. And what I was always taught is to advise people not to start isotretinoin before exams or before an important job interview or something, at a stable point in your life, essentially. Mm-hmm. And then there's a real minority of people who have had thoughts of self-harm or committed suicide that have been taking isotretinoin. Now, there's been a lot of studies into this, epidemiological studies and meta-analysis, and they've not found any causality between isotretinoin and the severe forms of mood change. But the concerns remain because there have been several significant negative patient experiences while they've been on the drug, either for the patient themselves or for their family. And so what happened was in 2023, or just before that, there was an independent kind of patient-focused expert review of isotretinoin, and they produced the new regulatory framework for how we prescribe it. And it's intended to do a good thing. It's intended to make sure that as professionals, we discuss the use of the drug, the benefits of it, and the potential risks, to ensure that we've told the patient properly about the potential changes on mood. And it's things like advising them to let someone close to them know they're taking the drug as well as themselves, so that in case somebody else notices something, they don't. And things like pregnancy prevention plan, it supports that, and it gave us a bit more leeway in people where we can give them 3 months rather than just the 1 month at a go. So there's been good things that have come out of it. In terms of kind of controversies with it, because there are quite a lot of issues with it that dermatologists and dermatology nurses have raised with the MHRA and with our body, the British Association of Dermatology, around about it. And it is things such as we now have to sit down with patients and go through a 5-page acknowledgement of risk form, which again is intended to do good things. I think we always, whenever we're prescribing drugs, we discuss the benefit as well as the risk and weigh up the two. So sometimes going through an acknowledgement of risk form is a little bit heavy-handed with some people, though the intention, I'm sure, is good. The other thing is that in patients who are below the age of 18, we now need to have 2 independent healthcare professionals to agree that isotretinoin is the best drug for that patient. And it's the kind of proportionality, I suppose, that we always are debating quite a bit, because we're a service under considerable pressure. The good thing is that we've got all these new treatments that we can do for people, but with that we now have more referrals and there's more skin cancer and there's less dermatologists around about the country. So trying to add in all these added things about isotretinoin has definitely put pressure on services. And the need for the 2 prescribers, you know, it's a tricky one, isn't it? If you think about the things in medicine that need 2 independent doctors to sign off, there's not many, beneficial medications that don't harm people that use. So it is quite a step for the MHRA to take.
Yeah.
I think.
It does seem a bit of an isolated case, doesn't it? As you say, there are a lot of other medicines that are pretty harmful where you don't have to go through those hoops. It's interesting. I mean, the mood things are also quite interesting, aren't they? Because, as you say, it's kind of anecdotal, isn't it? And yet, acne in itself is quite a mood changer, isn't it? So, having severe acne, it's nothing like that gets a teenager's brain depressed, really.
Exactly. Yeah, absolutely.
So it's interesting. And I think the other thing that I've noticed from what I've heard from my sons is that actually there's awareness of this drug amongst the teenage population. They all want it because they know it's effective. And so again, that's going to put pressure on the service, because they'll go to their GP saying, look, we want this drug. And so there'll be more referrals to you.
Absolutely. And I think that was part of the reason that the MHRA took action. Maybe I'm not part of the MHRA. So
No.
there was, so there have in the past been ways of getting isotretinoin over the internet, or, through ways that didn't entirely ensure that your patient was fully aware of the risks as well as the benefits. So with this, you've certainly got to see your patient in person, and you have to, you can't prescribe it the first time you've met them. You need to have made sure that they fully know what they're going to take. So I do see the kind of good points about it, but yeah, it has purely based on the kind of individual experience side from their independent review, taking quite a strong stance on the other.
Yeah, sure. We've gone for quite a long time, but maybe we'll just wrap up with one other topic, and that is sunlight, which obviously is very relevant to dermatologists, isn't it? Because we know that sun is bad for your skin, isn't it? It causes skin damage, it causes skin cancer, and yet there's lots of beneficial effects as well. It raises your mood, it produces vitamin D. And I just wanted to get your views about, is sunlight a good thing or a bad thing, or can it be, can the use of sun protection be tailored according to individual circumstances?
I think it's very much that. I think it's everything in moderation, really, isn't it, in life? So we do know that UV radiation causes breakages in DNA in your skin, and if not repaired, that leads on to skin cancer. And there's a lag. So the more damage that you build up over the years, the more likely you are to have problems in your skin when you're older. So the idea that we sometimes meet in clinic where people went on holiday last week and they're concerned about a mole isn't really what we're thinking of. Is protect your skin now so that you don't have significant problems in 10, 20, 30, 40 years time. And certainly if you have light skin and you're prone to burning, then yes, you're at higher risk of skin cancer. So you do need to take steps to avoid burning, look after your skin, and most importantly for everybody, really check your skin once a month. That gets you into kind of pattern recognition. All of skin lesion spotting is about pattern recognition, and our brains can do that really well, even if we don't believe they can. So if you look at your skin once a month, you get to know what's normal for you. And moles and other lesions on the skin can have a variety of different shapes and shades to them. That's all fine. If things are staying the same, that's okay. But if anything is changing and you can't explain why, that's always when to get it checked out. So that's certainly really important. Things can change. You know, you can have benign moles that over many years become elevated into bumpy moles. And you can have things called seborrheic keratoses that are common as anything and grow on everybody wherever they want to. And these are all absolutely fine. But anything that is changing week on week or month on month, and you can't explain why, I always get checked out. But it's an individual thing, because a lot of the research and the public health advice that we've had in the past has tended to come from people with light skin who live in very, very sunny parts of the world. And if you apply that advice and guidance to people who live in a northern part of Europe where there's far less UVB the whole year round, and they have a darker skin tone, then it's arguably not in their best interests. So we have got a lot more kind of public health work to do. There is nice guidance from 2016, which is really good, and it's good to have a look through it. And it talks about vitamin D supplementation, as well as populations who can be at greater risk of vitamin D deficiency, as well as the risk of skin cancer in lighter skin populations. So it's a good resource to look through. And vitamin D is controversial as well, because there's plenty of people who will say, oh, it's fine to stay out of the sun, you can just take vitamin D supplements. But there's a bit of debate around about that, again, which it's really useful to have a look through PubMed at the reviews and have a thought yourself about it. Certainly you can overdose on vitamin D supplementation. So people who take very, very high doses of it can get hypercalcemia and problems from that, which you can't get from natural sunlight. And certainly going outside and having a walk or a run is good for your general health. So we should never be advising people just to stay inside. But certainly if you're light-skinned and at risk of burning, then you want to protect your skin. And that involves having lunch in the shade and wearing things like a hat to protect your head, and being aware of how your skin is.
All very sound advice. Alex, it's been fascinating talking to you. I think we'll have to wrap it up there, but thank you very much indeed.
Thank you.